Good morning. This is Dr. Sonal Mehta. I am lead medical advisor in TAS. Intas is a leading pharma company having strong presence in fertility business and being a knowledge partner and to engage you all during this COVID outbreak. Intas Women Health team, headed by Mr. Satpathy, have organized this webinar. I welcome you all to the webinar on luteal phase support in IVF and evidence-based update given by Dr. Christophe Blockel from Belgium. You all are requested to put your questions through the chat box. Dr. Christopher Blockel is a medical director of the Center for Reproductive Medicine at University Hospital Belgium, Brussels. He is currently the president of the Belgium Society of Reproductive Medicine. Professor Blockel has special interest in reproductive endocrinology. He has published his scientific work in many peer-reviewed journals and lectured at numerous international meetings. With this, I welcome Dr. Blockel to begin this webinar. Over to you, sir.
Thank you very much, dear colleague. It is my my honor and pleasure to be with you in these very special circumstances. As you can all imagine, I would have preferred to be with you in India, but obviously this is not possible. And if we follow the news, the lockdown period is continuing at this stage. So we in Belgium are suffering. Already 2,000 people died in the last couple of weeks. So this is a very unfortunate situation. Of course, we are lucky that we are not in the United States, in Italy or Spain, where it is, of course, much worse than in our countries. But of course, to keep things going, I was asked to talk about the luteal phase in IVF, and of course, it's not so easy to give an evidence-based update because obviously the thing is that luteal phase support in IVF is actually quite complicated, and that's why it is called the black box in IVF. And the reason why is, of course, that you didn't need a synchronization between the two clocks, and the endometrium on one hand and the embryo on the other hand. And obviously, indeed, it is an extremely complicated process, the process of implantation. And there's a lot of cytokines, macrophages, and so on involved in the adhesion. But let's not go into detail about the immunomodulatory effect and so on. If we look at the normal endometrium, sometimes we have endometrium that are not receptor, the so-called repeated failed implanters, where no embryo will ever implant. And then on the other hand, you have people who have a two-receptive endometrium. Also, aneuploid embryos will implant and then cause miscarriage and even recurrent miscarriage. Obviously, the role of progesterone is crucial, and you know that that progesterone, let's say the hormone of the luteal phase, induces secretory transformations of the endometrium. You know, this decidualization and uterine receptivity for implantation. Progesterone obviously has an immunomodulatory effect, and also in terms of pregnancy maintenance. So you know that the removal of the corpus luteum before 7 weeks of gestation can lead to pregnancy loss. And the corpus luteum is the production industry of the progesterone. Now, what is the problem in IVF? Well, the problem is, of course, the duration of the luteal phase. In a normal cycle, we obviously know that the duration of the luteal phase is around 13 to 15 days. However, in a stimulated cycle following ovarian stimulation, you see that the luteal phase is much shorter. And this has been studied a lot in the past. If we perform an endometrial biopsy on the day of ovulation in a natural cycle, you see that there is not at all any secretory features. Maybe you see my arrow showing that there is no secretory features. But if we go now to the day of ovulation, of the day or of oocyte retrieval in a hyperstimulated cycle, and this is in a GnRH agonist long protocol, then you see clearly the secretory features here at the level of the epithelium. Now, in this graph that has been published by Freinasiak from the US a couple of years ago, you see that indeed in a natural conception or natural cycle, there is a synchrony between the embryonic window of implantation and the endometrial window of implantation. However, in a controlled ovarian stimulation cycle, you see that the endometrium is advanced. So it comes prior to that. So we have this advancement of the endometrium. So the embryo comes later. And this is, of course, the crucial aspect. Why do we see this? Why do we see a shorter luteal phase? Why do we have a luteal phase defect in IVF? Is it because we remove the granulosa cells during oocyte retrieval? Is it because the HCG that we give for the final oocyte maturation suppresses the LH? Is it because the high E2 levels are suppressing the LH activity? Or is it because of administering the agonist or the antagonist during ovarian stimulation? Well, actually, we have the answer. Because Fatemi in 2007, he published in HRU, in Human Reproduction Update, that the supraphysiological steroid levels that are created in a stimulated cycle are responsible for the iatrogenic luteal phase defect. So obviously, because we hammer our patients with so much FSH, estradiol is increasing so much, therefore, this supraphysiological steroid levels cause the problem of luteal phase deficiency. And it was Beckers from the Netherlands who said, well, if we look at the GnRH agonist protocol, and the long GnRH agonist protocol, which used to be the standard in the early days, and especially in the year 2000 and before that, we see that if no luteal phase support is given, that the duration of the luteal phase was much shorter. And the same was true in a GnRH antagonist cycle. Publication of 2003, we see that the luteal phase is also insufficient in antagonist protocols, so as well as in agonist, also in antagonist protocols, because of the supraphysiological estradiol levels. Now, is there a need for luteal phase support? The answer is, of course, yes. We know already that the duration of the luteal phase is much shorter. So we can see that also in the publications, and this is publications from the early days, that especially from van der Linden in 2015, that luteal phase support with HCG or with progesterone increases live birth rates dramatically as compared with placebo. So obviously, this is the fact. Also, the ESHRE recommendation based on level 1 evidence, progesterone is indeed recommended for luteal phase support following NXE treatment. So this is the review, systematic review and meta-analysis published by van der Linden, 2015, stating indeed that whether we give progesterone or placebo, that we will see significant differences at the end of the day. So then we come more or less to what kind of progesterone, and we will come back to that in 1 minute. But when we look at the differences between progesterone versus HCG as luteal phase support, actually both regimens can be given, but the reason why HCG belongs to the past as a luteal phase support is, of course, because of the incidence of OHSS. So please do use progesterone rather than HCG as a luteal phase support. The first question, when we look now into the more clinical data about luteal phase support, is when do we need to start? When do we need to start? And actually, we don't have so much evidence with regard to the ideal starting point of progesterone in the following the oocyte retrieval, but we have some data. We have 5 studies, randomized controlled trials that are published in the meta-analysis by Connell in 2015, showing that actually comparisons have been made to start progesterone before the oocyte retrieval, the day of the oocyte retrieval, 2 days later, 3 days later, even 6 days later, following oocyte retrieval. And obviously, in 2 categories of patients, there was a significant lower outcome, namely, if we start prior to the oocyte retrieval and if we start beyond 3 days after oocyte retrieval. So please, whether you start the day of the oocyte retrieval, the day after, or the day thereafter, there will be no difference in implantation nor in live birth rates. And then this is the most recent study from 2018, a smaller RCT with 230 patients included, where we have the comparison between, in group A, initiation 1 day following oocyte retrieval, or luteal phase support starting on the day of oocyte retrieval, and there was no differences in live birth rate per transfer cycle. So actually, it doesn't make too much sense whether we start on the day of or the day after. How are we going to administer our progesterone? We have so many different administration routes. We have so many ways of prescribing our progesterone. But if we look at this questionnaire, it was a survey in worldwide survey published by the group of Ziv Shoham from Israel. And there you can see that indeed still the vaginal route is still mostly used. So the micronized vaginal progesterone is mostly used all over the globe. And of course, sometimes there is a combination of tablets, so vaginal tablets, together with IM progesterone, especially in Asia and in the US, is often used. You see that still today the oral progesterone yields a minority of the progesterone supplementation. When looking at the data, Cochrane meta-analysis looking at 45 different randomized controlled trials and 13,000 women included, whether to use an oral, vaginal, rectal, IM, and so on administration route. Actually, we do not have evidence to state the superiority of one administration route versus the other. So actually today, we cannot state any superiority of an administration. When looking at the oral tablets, and you know the recently published Lotus 1 and Lotus 2 studies. So the Lotus 1 study was a randomized trial, and a very large randomized trial in practically 1,000 patients included. comparing oral tablets with the classical micronized vaginal progesterone. And also there was a non-inferiority between the two products. So very well designed study, and we were happy to participate in that trial in Brussels. Many centers were included and no differences at the end of the day. When we look at the micronized vaginal gel, 90 milligrams once daily, versus the oral dihydrogesterone, 30 milligrams, so 3 times per day, 10 milligram, the same observation was true. So both products have similar efficacy. Interesting data to see again a non-inferiority of different administration routes. Now that we know how to start and what to give, we also need to know when to stop our luteal phase support. And obviously, there we have some evidence. We have some evidence about the stop of the luteal phase supports, because everything is based on these old publications of Scott in 91, showing that as soon as we reach, let's say, the 5th gestational week, that we will have the luteoplacental shift. So the placenta takes it over completely as soon as we have around 35 days of pregnancy. So at around 5 weeks of gestation, we are actually safe. The luteoplacental shift has occurred and we do not need any more progesterone. But is this true? Well, yes, because if we look at 2 papers, there was the Anderson paper from 2002. You know that the people in the Scandinavian countries, they are always laughing at us because we extend always the administration of progesterone. But in this study, in the Anderson study, there was in 270 patients include or 300 patients were included in the study, and actually the comparison was as soon as the HCG is positive, so around 2 weeks following the embryo transfer, progesterone was stopped versus the classical 7 weeks, if I may say, and there was no difference in outcome. The same was true in the Gouch paper, a much smaller publication, 11 days after embryo transfer versus 6 weeks, also the same observation. So obviously, in terms of live birth, there was no difference at the end of the story. The meta-analysis goes further, and when we look at the miscarriage rates of extending the duration of progesterone beyond 4 weeks, 5 weeks of gestation, then you see exactly the same outcome. So no more miscarriages when we stop the progesterone administration after 2 weeks. But do we follow this paper? Do we believe this paper? Well, I think that we maybe first look at the ongoing pregnancy rates. When we look at ongoing pregnancy rates, again, evidence is there showing no difference in terms of ongoing pregnancy rates, whether we extend the or shorten, let's say, the period of progesterone until 11, 12, 14 days following embryo transfer as compared to longer duration of progesterone. So we can discontinue the progesterone once the positive HCG is detected. But I was mentioning 1 minute ago, do we do this? The answer is no, because we play better safe than sorry, as Leo published a couple of years ago. What we are doing, and again, we have this survey, worldwide survey, stating that actually probably only in the Scandinavian countries and the surrounding countries, their progesterone supplementation is stopped until a positive ATG test. And while I am telling you this story about the evidence that is available, that we can stop our luteal phase support as soon as the ATG is positive, we don't do that in the clinic. We still give until 7 weeks of gestation. Of course, we may not exaggerate, because some people give it until 12 weeks. Some people give it the whole pregnancy. And I heard even that some people give it during breastfeeding as well. But this is a joke. The luteal phase support in IVF. What about the dosing? What about the dosing? Well, actually, if we need to establish guidelines there, it is based on empirically studies, because there is no dose finding studies available. So we usually give 50 milligram of intramuscular, 25 milligram of subcutaneous progesterone, 90 milligrams once daily for vaginal progesterone. The micronized vaginal progesterone usually is 600 milligrams, and so on and so on. This is the mostly used luteal phase support. Now, should we adapt our dose of progesterone in the mid-luteal phase? Because here the distinction was made between less than 15 nanogram per ml and more than 15 nanogram per ml. And actually, there was no differences in pregnancy nor live birth rates. So when we increased the dose of progesterone in the group where we have a lower progesterone, then we did not see any significant difference. But when the authors, and here from Israel again, took a cutoff of a mid-luteal serum progesterone level, we are talking about fresh cycles, by the way, because the frozen embryo transfers is a complete different story. If we have a progesterone level of less than 17 nanogram per ml in the mid-luteal phase, then we observed lower cycle outcomes. So this is important. But again, if we add or increase the dose of progesterone at that stage, probably it does not make any sense. So let's use a fixed dose of progesterone throughout the whole luteal phase. Now, a few other topics to end, actually, because what about twin pregnancies? And I wanted to add these two slides of twin pregnancies, because maybe some of us might do some obstetrics instead of IVF in the last couple of weeks and in the next couple of weeks. But if we can add some evidence to the effectiveness of progesterone in the twin pregnancy, obviously, if we look at this meta-analysis in women who have a short cervix, vaginal progesterone is recommended in terms of avoiding adverse perinatal outcome. So yes, there is evidence of administering progesterone, especially here in twin pregnancies who have shorter cervix. And then it states, of course, that we need further research, but this study was based on 13 randomized controlled trials. Then we also have the effect of vaginal progesterone to asymptomatic women. So it's true that micronized vaginal progesterone certainly has its role in terms of preventing premature delivery in twin gestation. So this is something to rely on again a meta-analysis based on 6 studies. So yes, favor of micronized vaginal progesterone versus placebo in these pregnancies. We do not have time to cover the whole luteal phase in a frozen embryo transfer cycle. This is maybe a topic for a next lecture, but obviously when we are talking about the luteal phase in a frozen embryo transfer cycle, we cannot extend what we have been saying about a fresh cycle to a fed cycle. You know that we usually start the frozen embryo transfer cycle with estradiol. Whether we give estradiol valerate oral tablets or we give estradiol gel, and I put the conversion table underneath of the of the slide. So we usually use gel, estradiol gel in our clinic, or micronized estradiol tablets to prepare the follicular phase, to prepare the endometrium. And as soon as the ultrasounds shows a favorable endometrium, then we introduce the micronized vaginal progesterone, 600 or 800 milligrams before the embryo transfer occurs. So obviously, the luteal phase in a frozen embryo transfer cycle is different than a stimulated cycle. We do not have the corpus luteum, and you know the recent evidence showing that this lack of a corpus luteum might have some implications. We have observed recently in the papers of 2019 that the lack of a corpus luteum, the lack of relaxin, for example, might enhance the incidence of preeclampsia. So let's be careful with that. Secondly, the duration of the luteal phase, the duration of progesterone administration should be longer, of course. We cannot stop as soon as we have a positive pregnancy test. It should be continued until the luteoplacental shift has occurred. And in an artificial cycle, we need to play on the safe side. So, ladies and gentlemen, if I can conclude, we know that progesterone has a crucial role for implantation and early pregnancy maintenance. Luteal phase support is necessary. We do need it in agonists and in antagonist protocols, and it should be started on the day of or the day after the oocyte retrieval, but no later than 3 days following the oocyte retrieval. I am talking about HCG triggered IVF, of course. Controversy regarding the stopping of the LPS. When do we need to discontinue? Evidence states that we can discontinue in HCG triggered patients as soon as the HCG levels are positive, but we do not perform that in practice. And vaginal progesterone is still worldwide mostly used for LPS. Oral progesterone, dihydrogesterone, has a similar efficacy as micronized vaginal progesterone. And then last but not least, these data cannot be extrapolated to a frozen embryo transfer cycle. Thank you so much. We cannot hear you, Sona.
Hello, sir.
Yes, we can hear you.
Yeah. So thank you, sir, for enlightening us on the latest update on the luteal phase support. And I do see many questions regarding luteal phase support. Many of them are already answered. One of that is, can we measure progesterone level on the day of transfer in FET cycle to ensure our progesterone support is adequate?
Yes, yes. Unfortunately, I did not add a slide about that, but I think this is one of the crucial questions now. And since we are performing so many freeze-all cycles, which I did not highlight today, I was talking about fresh IVF cycles actually exclusively. And at the end of the presentation, I was showing only one side about the frozen embryo transfer cycle. But it's true that now more and more data are coming about the importance of progesterone in the luteal phase of a frozen embryo transfer cycle. In the world, we mostly prepare the frozen embryo transfer in an artificially prepared cycle, not in a natural cycle. And obviously, there is studies, and it was Elena Labarta from EV, who started with that in 2017 in human reproduction, showing that when you have a level of less than 9.2 nanogram per ml on the day of transfer, less than 9.2 nanogram per ml on the day of embryo transfer, that the outcome was significantly lower. But of course, then the next step is, well, if we have those low levels, lower than 9.2 nanogram per ml, low levels of progesterone on the day of transfer, should we add some other progesterone? And this is the subject of her next study. Actually, what we are doing now is randomizing patients who have these low levels of progesterone into continuing progesterone versus adding some subcutaneous progesterone and see what it will give. So this is for the future. But obviously, there is data showing that on the day of transfer, if progesterone is low, then you have a worse outcome. I would like to add that there's also another study by Polizos, who is stating, well, maybe we should measure progesterone the day before frozen embryo transfer, because then we can still act, we can still postpone, delay, or cancel the frozen embryo transfer when the embryo is not thawed yet. So there's also a predictive value of progesterone measured the day before the embryo transfer, also stating more or less the same. If we have lower levels of progesterone, outcome will be lower. So in the end, what we should do is individualizing the frozen embryo transfer. We have been talking about individualization of ovarian stimulation, individualization of the trigger, individualization of the frozen embryo transfer is, of course, the next topic, especially the luteal phase.
Right, sir. There is one another questions. Optimal dose of NMP vaginal gel 8% in FET cycle, and do we need to add difastone or dydrogesterone or natural micronized progesterone?
So the question is in a fresh cycle or in a fed cycle?
Like FET cycle.
So in a fed cycle, we usually use now, but again, this is based on empirical data, we use in the follicular phase 6 milligrams of estradiol valerate or estradiol gel 3 pumps during, that's another study, during 7, 10, or 14 days. We are actually now in the stage of comparing 7 days versus 14 days of preparation of the endometrium in a randomized way. And some preliminary data show that actually whether we give a shorter or a longer duration of E2, that the same observations are there. So this is quite a promising study, because in terms of time to pregnancy, it will hopefully show the same results. So 7 days or 14 days of preparation of E2. Once we have a nice endometrium, meaning that we have a triple line of 7 millimeters, then we start with the progesterone, and we have changed our policy actually from 600 milligrams MVP into 800 milligrams of MVP for two reasons. First of all, we are struggling like many others with miscarriages, and one trial to in terms of avoiding or lowering the miscarriage rate, we increased the dose from 600 to 800. Besides that, instead of administering the progesterone 3 times, we now do it 2 times. So 2 tablets of 200 milligrams in the morning, and then 2 tablets of 200 milligrams at night. So we only administer it twice. So this is the micronized vaginal progesterone. So there was also a question with regard to dihydrogesterone. We have some retrospective data about dihydrogesterone in the luteal phase of a frozen embryo transfer cycle, but there is no prospective evidence about that. So we need to do that study as well.
Right, sir. Will too much of progesterone with different routes affect pregnancy outcome regarding the suppression of progesterone receptor downregulation?
Well, actually, there is not only the combo treatment during ovarian stimulation, but also a lot of combo or combinations of progesterone in the luteal phase. Up until today, there is no evidence that combining different routes of progesterone will enhance pregnancy. So this is a reality. Many of us, many of the physicians are combining vaginal, oral, and intramuscular administration. First of all, in terms of patient friendliness, it is not advised. Secondly, in terms of cost, it is not advised. And thirdly, there is no evidence to defend these combination preparations and different routes of progesterone administration.
We can stop support in cycle with functioning corpus luteum, but what about the recipient cycle or FET cycle? When is the right time to stop?
When well, first of all, we are not amused with the results that we see. We are not amused with the results that we see with regard to preeclampsia. So, of course, the fact that we can plan, that we can schedule our frozen embryo transfer cycle when it is artificially prepared offers a lot of possibilities. Now that we see these recent data showing the increase of preeclampsia, we are struggling with that. So the question is, do we really need to stop administering the frozen embryo transfer cycle in an artificially prepared cycle? Do we still have to go to the natural? Do we have to go back to the natural cycle? Which is of course a drama in many centers because of the planning, because of the scheduling issues. But if we stick to the frozen embryo transfer cycle in an artificially prepared cycle, then obviously we should continue the luteal phase support until 7 weeks of gestation. We have a protocol where we give it until 7 to 8 weeks of gestation, and then we decrease the dose in a soft way, let's say. So then we decrease the dose from 800 to 600 to 400, 200 milligrams of progesterone, and then we stop. So at 9 weeks of gestation, everybody has stopped its luteal phase support in an artificially prepared cycle.
There is one question. Should we increase the dose of progesterone in case of bleeding PV in first trimester for FET or fresh transfer?
Well, there we need to refer to 2 trials. We have the PROMISE trial and the PRISM trial. You know that Kumarasamy from the UK has done 2 large randomized trials in 2015 and last year, showing that when we administer progesterone in patients with threatened abortion and in bleeding in the first trimester, if we administer micronized vaginal progesterone or placebo, that it did not show any difference in terms of miscarriages. So these studies, of course, very important randomized studies, have shown that in terms of miscarriage, it will not help.
What is your experience on subcutaneous aqueous progesterone?
I like the product. I like the product. Of course, it is an expensive product, so we don't have so much experience with it. It is much more expensive than the other products. But in terms of evidence, scientific evidence, and this is of course most important, we do not see any difference in efficacy, in safety, comparing subcutaneous progesterone versus micronized vaginal progesterone. There is a very elegant paper from Gillian Lockwood showing that there is no difference between subcutaneous and micronized vaginal progesterone.
And what dosage do you use?
Well, if we look at the subcutaneous injections, we usually use the 25 milligrams once daily injection. When we look at micronized vaginal progesterone, we have the 3 times daily 200 milligrams administration.
Right. There is another question. Does the cutoff of 9.9 nanogram per ml vary with the route of administration of progesterone, vaginal, oral, or IM?
That's a very good question. That's a very good question. And of course, the answer is yes, it varies. So first of all, it is 9.2 nanogram per ml when micronized vaginal progesterone was used. We do not have data with regard to the other routes. So actually, whether we use intramuscular or subcutaneous, probably the cutoff of progesterone will be different. So we do not know this.
Correct, sir.
That's a very important question.
Yes, sir. Sir, what is the pathophysiology of preeclampsia in FET cycle and how to prevent it?
That's also a crucial one. So it's true that nobody in the world wants to go back to the natural cycle to prepare the FET. And of course, then we want to know why in an HRT cycle, in an artificially prepared FET cycle, why do we have more preeclampsia? So then we have to look at the corpus luteum, because there is a lack of the corpus luteum in the frozen embryo transfer cycle that is artificially prepared. And obviously, there is a lot in this corpus luteum. And relaxin is named to play the major role in this pathophysiologic pathway, and probably that is the clue. So the question is now, could we maybe add relaxin to the frozen embryo transfer cycle, or administer relaxin to our patient to see whether that will help, or should we go back to the natural cycle to prepare the endometrium? So that's quite a crucial question, but we don't have the answer yet.
There is one question. Can we increase the dose of estradiol to 8 milligram during endometrial preparation? It's beyond 8 milligram.
Well, we can do everything, but I think that the thin endometrium story is, of course, a presentation on itself. We look more at the aspect of the endometrium rather than the thickness of the endometrium. You have also the crucial, let's say, the crucial role of the ultrasound in the assessment of the endometrium. We have been discussing this earlier this year already in India. And obviously, if we have a nice aspect of the endometrium, we can proceed. if we want to increase the dose from 6 milligrams to 8 milligrams, fine. What we usually do is administer the micronized vaginal, the estradiol that we give normally in oral tablets. You can also administer it vaginally. And this gives quite nice results. So the E2, the Proginova tablets or the estradiol tablets, you can administer them vaginally as well. Another possibility is to change from estradiol tablets into estradiol gel. Estradiol gel is also a very good option to sometimes increase the endometrial thickness. We usually use the estradiol gel in our IVM, in vitro maturation cycles, to prepare the endometrium, and it works very well.
So in what dosage do you use, sir?
Well, we start always with 3 pumps per day of estradiol gel. If the endometrium is not as we wish, you can increase until 6 pumps per day. And then after 1 week, we perform the ultrasound scan to see whether the endometrial thickness is sufficient to plan our embryo transfer.
Thank you, sir. Is there a role of measuring E2 levels during FAT cycle?
Aha. I like the question because there is a paper that is recently accepted, actually last week. It was accepted in Frontiers of Endocrinology from Shari Mackens, and you can look for it. I am the last author. We did the study because we were asking ourselves, we have E2 levels that are varying so much between 100 and 2000, especially when you use the estradiol gel. Does it play any role? And actually the answer is no. We divided our E2 levels into quartiles, and we observed that the E2 level on the onset of progesterone, so after 2 weeks, for example, of preparation of the endometrium, does not play any role. So actually, we can stop measuring E2. We don't need endocrine monitoring except for progesterone, of course. I would measure the progesterone to see if there has been no premature luteinization, if there has been no progesterone rise.
Low dose HCG in luteal phase support for FAT cycle, is it beneficial?
Important question. Lack of evidence, but I like the idea. The fact is that there is a complete lack of data. There is a complete lack of evidence, but the use of low doses of HCG in an FET cycle, when it has been prepared artificially, is nice to replace the progesterone, not to add with the progesterone, because there is some evidence. You know that Griesinger in 2007 published a study that was a randomized study in a classical FET cycle, so with progesterone, and then once the addition of HCG 5,000 units, and there he did not see any difference. So whether we add HCG, let's say, to induce luteal phase or to cover the first days of the luteal phase, there is no evidence. But let's say low doses of HCG at regular time points, that could replace the other progesterone, for example, micronized vaginal progesterone. But again, a lack of data.
Is there any upper limit of progesterone beyond which we should not transfer?
Well, of course. If we so you mean a lower level of a progesterone?
No, not the upper limit.
Upper limit of progesterone. Up until today, when we look in, and the most of the data come from the EV Valencia in Spain by Elena Labarta, and up until today there is no upper limit of progesterone beyond which we should refrain from embryo transfer. So the answer is no.
Any role means role of estimation of progesterone on day of OPU or on day of trigger?
Well, yes, of course. If we go into the discussion of the importance of progesterone during ovarian stimulation, we see that the last day of the ovarian stimulation probably plays a crucial role, and if progesterone is increased on the day of trigger, then we have lower outcomes. We all know the paper of Ernesto Bosch, again from Spain, who stated in 2010 that whether we're using agonists or antagonist cycles, that when we have an increased level of more than 1.5 nanogram per ml, that ongoing pregnancies and live birth rates will be significantly lower. So we have been using this cutoff of 1.5 nanogram per ml as routine clinical practice. Many papers have discussed the importance of progesterone in the follicular phase, the late elevated progesterone in the follicular phase, but we also should should be careful with the duration of the exposure to elevated progesterone. There are some data showing that when you have an extended period of progesterone rise, that also you could have lower outcome. So this is also extremely important. But the answer is yes. On the day of trigger, progesterone levels should be less than 1.5 nanogram per ml. Otherwise, we need to use the freeze-all cycle. There is no predictive value of the progesterone on the day of oocyte retrieval. So no reason to do an endocrine monitoring on the day of egg retrieval.
Next question is, what is your recommendation of progesterone supplementation in IUI?
There is data. If we use a natural cycle, if we use a clomiphene citrate cycle, if we use an letrozole cycle, there is evidence that whether we use nothing versus micronized vaginal progesterone, that the outcomes will be similar. So no need to give any supplementation in IUI cycle. If we are going to an administration of FSH, if we use also some antagonist in the IUI mild stimulation cycle, then we do need luteal phase support for the same reason as the IVF. We have supraphysiological E2 levels. We do stimulate our patients with some FSH, whether it is at the end or in the beginning of the follicular phase, and then we do need some luteal phase support. So the answer is certainly yes. And I think, if I recall well, if I'm well informed, in India, that you do a lot of inseminations with FSH administration in the follicular phase. In that case, please provide luteal phase support.
Correct, sir. Luteal phase support in different agonist, is the luteal phase support different in agonist from antagonist protocols?
Well, actually, no, because if we foresee a GnRH agonist long protocol, which is HCG triggered, we use 600 milligrams of micronized vaginal progesterone. If you use the antagonist protocol HCG triggered, then you use the same luteal phase support that you used in the long agonist protocol. So there is no difference there. Of course, if you trigger in a GnRH antagonist cycle, if you trigger your final oocyte maturation with a GnRH agonist, and you still want to perform a fresh embryo transfer, so you do not want to apply a freeze-all protocol for I don't know which reason, then you need to change your luteal phase support, because then you need the so-called Humaiden protocol, which means that we add 1,500 units of HCG 1 hour after the oocyte retrieval, and then provide a normal luteal phase support. But this is a different story.
Should we look upon progesterone as completely innocuous? Besides local side effects, it does have some derangement on glucose metabolism.
Sorry, I'm not sure I get the question. Sonal, can you?
So it's rather than questions, it is, should we look upon progesterone as completely innocuous? Besides local side effect, it does have some effect on glucose metabolism also. So that is can be considered as innocuous and can we use it maximum dosage or so?
Well, it depends when you are talking. If we are talking about the normal luteal phase, I think that in terms of metabolism, we are not taking big risks. However, if you go beyond and during pregnancy, I think it is could be also harmful. So don't continue, like I made the joke, until the breastfeeding. It of course makes no sense to give it in a normal pregnancy throughout the pregnancy. But I'm not completely aware about impact on glucose metabolism, to be honest.
Right. Any role of enoxaparin, prednisolone, and GCSF in case of recurrent implantation failure?
Well, of course, this could be a topic of another
Right.
lecture. So when we look at these products, and I think that evidence is still in the first steps. We need to know that with regard to the so-called add-ons, they are often used in many countries. We should do some very nicely well-designed and properly built studies to see whether it really helps. But the data are coming. We are doing some studies with several add-ons, so we are sure that that evidence will be coming soon.
Sir, if patients has endometriosis or adenomyosis, for how long should progesterone be continued? Is it same or we need to extend?
No, it is very well established that when you are talking about endometriosis and also adenomyosis, that the progesterone extension is not valid. So we use the same progesterone administration in these categories of patients.
What about the cases with threatened miscarriage following embryo transfer and progesterone use? That is same as bleeding.
Yes, so we have been talking already about the PRISM trial and the PROMISE trial. I really recommend you, if you want to read one paper, read the Kumarasamy paper, which shows us indeed very interesting data with regard to these products. It's true that we have some very relevant data on the PRISM and the PROMISE trial. If you want to, I can share some slides about that. I think it will bring us a little bit far. But actually, in terms of recurrent pregnancy loss and miscarriage rates, there was no real no significant increase, let's say, in live birth rates with progesterone in the first trimester among women with bleeding early in the pregnancy. So that is quite important to know.
Fine, sir.
So the
Mid-luteal level of
PROMISE and the PRISM trial. So it has been published. So the Kumarasamy, so the last Kumarasamy trial has been published in the New England Journal of Medicine in 2019. So you can easily search that. So 2019, the PROMISE study, recurrent pregnancy loss. Correct. Yes, sorry, I interrupted you.
Yeah, mid-luteal level of 15 to 17 nanogram per ml. Would you expect different values with control ovarian stimulation cycle where number of oocytes are more? If yes, what value you are looking at?
Interesting question. Up until today, we do not see any differences in progesterone levels when correlating about number of oocytes. So we do not see the same like the E2 levels, increasing E2 levels or progesterone levels in the follicular phase, because we also see that by increasing number of oocytes, also increasing levels of progesterone levels, but this is not observed in the mid-luteal phase. So the answer is no.
Right. Sir. Any role of GnRH agonist in luteal phase support?
Studies of Tesarik. Tesarik has published a very few studies, and also Pirar. So there's a couple of publications on the GnRH agonist in the luteal phase. My question has always been, why do we need to hammer our patients with more injections in the luteal phase? They have had enough in the follicular phase. That's one. But it could be an elegant way of, if, for example, there is an allergy to progesterone, it can be given. There's very nice papers from Tesarik and Pirard. So Tesarik and nice papers that, so there is some evidence about GnRH agonist, yes, but we do not use it in daily practice.
Correct. Is there any role of estradiol in luteal phase support in IVF pregnancy?
Fatemi did a study, a randomized study, comparing progesterone versus progesterone plus E2 plus micronized estradiol, and actually the results were the same. So similar outcomes when looking at addition versus no addition of E2. That was completely the same.
But if you use, in which circumstances do you use?
Sorry. I think that now we need to be on the same line. It's true that there was no difference when using in a fresh IVF cycle. When we are talking about FET cycle, we of course use the same dose of E2, whether we are talking about the estradiol gel or the estradiol tablets. We are continuing the same dose of 6 milligrams of E2 in the follicular phase as well as in the luteal phase. So that remains the same. That is obviously a reality, yeah, of course. So then, of course, when we continue the progesterone in the luteal phase of an FET cycle, we also continue the E2. And then we also stop at around 8 weeks of gestation with the E2 as well as with the progesterone. Yes, sorry, to be clear.
Yeah, thank you. When the beta HCG values are less, what support we can give to achieve clinical pregnancy, and what are the chances?
Sorry, come again. In which situation?
Sir, it is when the beta HCG values are less, what support or addition of support we can give to achieve a clinical pregnancy, and what are the chances?
No, if HCG levels are low, you know that it can be a sign of aneuploidy, but their progesterone will not help us any further. So they're increasing the dose, changing the administration route or whatever will not help us any further.
We are going beyond time, but there's one question. Are replacement cycle, natural cycle FET, more sensitive to the timing of starting progesterone as compared to stimulated OPU ET cycle?
Interesting question. Interesting question. And the reason why is that we did a study. We did a study in FET cycle. FET, complete natural cycle awaiting the LH peak, versus natural cycle with progesterone, with HCG plus luteal phase support, versus HCG alone. So natural cycle, spontaneous, um, um, pregnil, so HCG plus progesterone versus HCG alone. And the best group was the LH spontaneous, significantly higher pregnancy rates. And the paper has been published by Montagu in Human Reproduction in 2016, Montagut. And she did the study. And the discussion was, of course, why does this HCG triggered plus luteal phase support um, group performed worse? Probably because we started the luteal phase support too early. We started the day after the HCG injection. But this is too early because when we extrapolate to a natural cycle, progesterone starts rising only very slowly, only a couple of days after the HCG in a natural cycle. So what we said is, let us change our policy. If we do want to prescribe luteal phase support in a natural fat cycle, then we start it on the day of embryo transfer. Because the first days, there will be no luteal phase insufficiency. It will be more in the mid-luteal and later phase. So this is why we said, let's change our policy. If we provide luteal phase support in a natural cycle, we started on the day of embryo transfer and not before that.
Right, sir. Before we conclude, there are many questions, but a couple of questions I will ask you. Luteal support for frozen transfer cycle, role of measuring estrogen that is already covered, Doppler findings before progesterone, and serum progesterone after it start before transfer.
Yes, I think when you are a good ultrasonographer, when we have the tools and the means, then it's true that the Doppler plays an important role in assessment. So this, I fully agree.
Uh, and what is the similar question? What is the best possible way to identify luteal phase defect scan, endometrium study, or role of ERA?
Well, so the ultrasound certainly has its role. I think, and also in India, many people are really specialists with regard to the ultrasound scan and assessment. With regard to the ERA, there I think the evidence is disappointing us a little bit. We know that whether we use ERA or not, that the personalized frozen embryo transfer cycle does not seem to play such a crucial role in terms of pregnancy outcomes. So I would maybe not give my full credits to this endometrial receptivity array test.
Last question, sir. After failure of pregnancy after ICSI, what are the possible causes of amenorrhea in spite of no pregnancy? What are the possible treatment?
Of amenorrhea?
Yeah. Shall I repeat?
Normally,
After failure of pregnancy after ICSI, what are the possible causes of amenorrhea in spite of no pregnancy? What are the possible treatment?
well, if you performed an ovarian stimulation cycle, if you gave an HCG injection, and if you provided luteal phase support in a correct way, then when you stop the luteal phase support and the patient is not bleeding, she is probably pregnant. If she is not bleeding for another reason, then it should be because of an endometrial pathology. If there was no endometrium that was building up because of a partial or complete Asherman syndrome, but I cannot think of any other reason, because otherwise she should bleed.
There is one question. Is concept of progesterone resistance true? If so, does using high dose on extra day of progesterone solves the asynchrony?
Yes, the answer is probably yes. This is an important point. It should be a long answer. Actually, the progesterone resistance. But I think that the colleague is right. Yes.
Correct, sir. All the viewers have made comments that this was a wonderful lecture, and we, on behalf of our viewers as well as on behalf of Intas, we thank you, sir, for enlightening us on this literal faith support latest evidences. Thank you, sir.
Thank you. Bye bye.
Thank you, Dr.
Bye.
Blakey.
Bye bye to everybody.
Pandemic.
So with regard to the COVID situation, we have a guideline. We have a guideline that we are strongly discouraging any elective IVF treatments. So what we have been doing since the 15th of March already, we have not started any IVF treatments, but have just continued the patients who were under stimulation, and then we performed a freeze-all cycle for everybody. So we stopped completely the fresh embryo transfer, because although the early data from relationship between COVID and pregnancy were quite promising, recently there is a couple of papers, in the last few days, there is a couple of papers showing possible complications because of COVID in terms of pregnancy. And there is more preeclampsia, stillbirth, miscarriage rates, and early early delivery, and so on. So we need to be very careful and cautious. The only reason why we continue our activity is for oncofertility reasons. So we have divided a guideline in Belgium for oncofertility reasons, people who need to start chemotherapy for breast cancer, for example, and so on, that we can still stimulate those patients and maybe perform an ovariectomy and ovarian freezing, in vitro maturation, and so on, if needed. So for example, now in our center, and you know that we do around 500 cycles per month, or 5,500 cycles per year, that we are now having 2 or 3 patients under stimulation for oncofertility reasons. And this can be done in safe circumstances. Prior to the ovarian stimulation, they will undergo a CT scan and a PCR nasopharyngeal test to see whether they are COVID positive or not.
Thank you so much, sir.
Okay.
Thank you.
Welcome.
Thank you.